Okay, so now let's get started. I'd like to welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olewski, and I'm the host for the Vasculitis Foundation's educational webinar series. I'm also a patient living with MPA vasculitis. These webinars are part of the Vasculitis Foundation's commitment to patient education, and we would like to thank our sponsors, AstraZeneca, Amgen, and Novartis, for supporting these webinars. And today's webinar is an overview of adrenal insufficiency. After we finish this webinar today, there will be a recorded version of on the Vasculitis Foundation's YouTube channel, and everyone who's registered today will receive an email with a link to it as soon as it's available. But before we get started today, it's good to go over a few details. Because this is a live webinar, we've muted everyone except our guest speaker. In today's webinar, Dr. Alexandra Villaforte will educate us about adrenal insufficiency. And after her presentation, you'll have the opportunity to ask her questions. These questions will be asked by typing your questions into the Q&A box. You can find the Q&A box at the bottom of your screen. Sorry, had a little issue there. You can find the Q&A box at the bottom of your screen, but if you don't see it, just click the three dots to the far right of your screen that says more, and please make sure your question is a general question about adrenal insufficiency, and Dr. Villaforte can answer questions like that if it is specifically about the topic, but not too much if it's about anything about personal medical issues, because she's not your doctor. So 1 second here. There we go. There's also a chat box. This is not an area for questions, but it is an area to chat with others on the call. So remember, Q&A box for questions, chat box just for talking to other people on the call. And now that all the housekeeping is done, I'd like to introduce our speaker. Dr. Alexandra Villaforte is a staff physician at the Center for Vasculitis Care and Research at the Cleveland Clinic. And she's an associate professor of medicine at the Cleveland Clinic Lerner College of Medicine in Cleveland, Ohio. Welcome, Dr. Villaforte. It's so great to have you here with us today.
Thank you. Thanks so much for the kind introduction. I have no disclosure that is relevant to this talk. It is a great pleasure to be here. And I'll start by sharing my slides, maybe?
Yes, please. That would be wonderful.
All right. So this is a great topic. I'm very happy to be here and talk to all of you about it. We do get these questions every day in clinic. So it's a very important topic. And if I don't cover some of your questions, please feel free to ask. I'm going to make this short, so give you a lot of time to ask questions. And we can make this very interactive at the end. So we're talking today about adrenal insufficiency. The outline of this talk, I'm going to start by a small introduction, very short, about the use of corticosteroids in vasculitis. Then we'll move on to adrenal insufficiency. And finally, we'll end with how can we minimize the risks. So the big question is, why are corticosteroids still needed for the treatment of vasculitis? Every single new drug that is trialed or researched, and new drugs that are being studied every day, have the main purpose to eliminate the need for corticosteroids. That's one of the main goals that we have in general in the treatment of all vasculitis. We wish we could skip using steroids because of all the side effects that you're all very aware of yet. However, the steroids have a very intense, a very powerful anti-inflammatory effect, and also an immunosuppressive effect that is very quick. And very often in vasculitis, we need a quick treatment to suppress the inflammation, sometimes because there's a life-threatening situation. Corticosteroids, so we'll talk about it and I'll call it steroids. and I'm referring specific to the group of steroids that's called glucocorticoids, is the most powerful anti-inflammatory drug that is available. And it starts to work within hours. So it's what we have available to stop a very serious sequence of events or inflammation that can be life-threatening, like I said. And also at higher doses, a little shortly after the anti-inflammatory effect, it starts to have an immunosuppressive effect that is also very important, especially at the long-term use. So we use steroids in two different situations in vasculitis. At the beginning of therapy, because we want a very quick effect, but sometimes for some types of vasculitis, it's necessary to continue the steroids at a very low dose, not just because there are side effects or problems with stopping it, but because sometimes it's part of the treatment, as we sometimes lack other options. Let me stop here before we go into adrenal insufficiency and explain, not in a lot of details, what happens to our body when we're taking a drug that is a steroid, a corticosteroids. So this is the hypothalamus pituitary gland adrenal gland axis. So HPA just stands for the hypothalamus, which is in the brain. It's pointed there. The pituitary gland is right below it in the brain, is another gland. These are all glands that produce hormones. And the adrenal glands, they sit right on the top of the kidneys. And the adrenal glands, as you know, is responsible to make cortisol, or our own steroids. How does that happen? The hypothalamus produces a hormone called CRH, which stimulates the production of another hormone that's called ACTH in the pituitary gland. ACTH is the hormone that directly stimulate the adrenal glands to produce cortisol. So these are loops of stimulation, meaning that these hormones, they're telling our adrenal glands that we need to make steroids, maybe because of stress, physical stress, mental stress, but cortisol is necessary for many bodily functions. Now, once we have enough cortisol in our body, there is a negative feedback loop, as you can see with the red arrows. So if we have enough cortisol, it will suppress the production of ACTH by the pituitary gland. It will also suppress the hypothalamus from making CRH. In this way, it stops the adrenal glands from producing too much steroids. So it keeps a nice balance between production of cortisol and suppression. That's our body working very perfectly. So what happens when we're taking steroids? Well, let me go back to this. So when we're taking steroids, we're taking cortisol in a synthetic way. And it tells our body that we don't need to make cortisol because the cortisol levels go up and will suppress the production of ACTH and CRH by the pituitary gland and by the hypothalamus. So by taking the steroids, we're telling these glands, the hypothalamus and the pituitary gland, that they can stop stimulating the adrenal glands. When that happens, the adrenal glands stop producing or making cortisol. And what happens is they start to shrink. They're not needed anymore, and they stop working. They go into a deep sleep. So taking these corticosteroids can cause the adrenal glands to decrease or completely stop the production of our own cortisol, and they go into this sleep-like state, a very deep sleep. So what is adrenal insufficiency? Well, when our adrenal glands do not make enough cortisol once after we stop taking steroids. So there are two different types of adrenal insufficiency. One that's called primary, that we're not going to talk about today. That's when there are diseases or other problems affecting directly the adrenal gland. And a secondary adrenal insufficiency, which is caused by the corticosteroids that we're taking, is when the hormones produced by the hypothalamus and by the pituitary gland are suppressed. So adrenal insufficiency means our adrenal glands do not make enough cortisol after the person stops taking steroids. So there's a situation that there will be no cortisol or not enough. Now, it's very important to remember, because prednisone is so often used, that those synthetic corticosteroids, such as prednisone, is probably the most important, the leading cause of secondary adrenal insufficiency, especially with prolonged treatment after it's stopped very quickly. Up to 48 to 50% of people taking steroids can go into adrenal insufficiency. So what are the risks of developing adrenal insufficiency? Well, there are many different situations. If someone is taking 5 milligrams a day or more of prednisone for at least 4 weeks, they are at risk of developing adrenal insufficiency. So it's important to know the dose, what kind of steroids, and what's the duration of steroids, so you know the risks. Now, to give an example, if someone is taking a different kind of steroid, such as Decadron, which is much more powerful, then you have to do the equivalent dose. So taking a lot less of it may have the same kind of problem. So the 5 milligrams that I put here, it applies to prednisone. So taking 5 milligrams a day or more for 4 weeks or longer will put someone at risk of developing adrenal insufficiency once the prednisone is stopped. Now, I want to reinforce that adrenal insufficiency happens when the steroid dose is either dropped too low or it's off, not while people are taking higher doses of prednisone. And we'll go back to that. Other situations of risks: when people get 3 or more rescue courses of prednisone over 6 to 12 months. So these are short courses, maybe less than 4 weeks, but multiple courses over a period of at least 6 months. That's more common to see on people who have asthma, because they need for their asthma attacks. But sometimes when the vasculitis flare up, you have to take a short course of a higher dose of prednisone. Also happens when people are taking high dose of inhaled steroids. Remember that people with asthma take inhaled steroids every day. If the total exposure of steroids of any combination of oral, nasal, or any way the steroids can be given should be added up so that we have a total dose, and it places the person at risk as well. So sometimes we don't think that a little steroid cream can do any harm, or maybe just one joint injection, put some steroids in the knee, maybe some eye drops. Those are things that usually are ignored. But when you think about all the exposure that one person have from different types of steroids or different ways the steroids get into your body, they count. They all are steroids and will work together to suppress the adrenal glands. Also, remember, there are other medications that can be combined with steroids, and we're just missing it, not paying attention. For example, there are some antifungal medications that come combined with steroids and may be prescribed in different situations, not because of the steroids, but it happens to have steroids with it. Now, what are the symptoms of adrenal insufficiency? They're very non-specific. People have aches and pains affecting mostly joint muscle, fatigue, loss of appetite, nausea, vomiting, some abdominal pain, which is less common. Low blood pressure is not very common because that part of the adrenal gland is not suppressed, but it can happen as well. So how can we try to avoid the risk of adrenal insufficiency? Now, first, keep in mind one important information. The risk of adrenal insufficiency can last for 12 months after stopping the steroid treatment. What do I mean by that? Is that it might not happen immediately. It might happen a little bit later. So remember that it's very long until the adrenal glands can recover. It takes up to 12 months. So that's why we taper the prednisone so slow. Now we have to keep in mind, so when we decided that steroids are no longer needed, the doses should be very gradually reduced to make sure that we give enough time for the adrenal glands to wake up again or grow again and start producing sufficient cortisol. Now, most of the time, the diagnosis is made without proof. So it's based on the symptoms, based on the amount of exposure to steroids, based on what kind of taper that person has had. So we look at multiple factors and decide, I think that person has adrenal insufficiency. And we don't have to prove by doing tests because tests are not great. I'll talk a little bit about them. But we can make a clinical diagnosis and correct the problem. There is no need to prove unless our efforts to correct the problem are not being successful. So in the case that someone needs a test, we do two tests. So everybody probably has heard about the basal cortisol levels. It's not a perfect test. It's actually a very poor test to diagnose adrenal insufficiency. Why is that? Because the cortisol secretion varies a lot throughout the day. It's not constant the same. It is in peaks. So there's a peak in the morning, there's a peak late afternoon around 4 p.m., and maybe another one later. So we would have to do the blood test at certain times. It's usually not a definitive test. A single time serum cortisol value may be inconclusive to determine whether there's adrenal insufficiency. So we go on to what we call a confirmatory test. So that hormone, ACTH, that is produced by the pituitary gland, and that's the main hormone that stimulates the adrenal gland to produce cortisol, can be checked in the blood. That is called the ACTH stimulation test. As you can imagine, if someone is taking steroids and is suppressing the ACTH by the pituitary gland, if you do a blood test and the cortisol level is low because the adrenal glands are not working, what's going to happen to their hormone, the ACTH? It's going to be very high because it's trying to stimulate the adrenal glands. Now, if there is enough cortisol, if someone is taking a high dose of prednisone, that level of ACTH will be suppressed. So this is a better test that tells us what is happening to steroids. Now, another point that I want to make about not only the gradual taper of the steroids, but sometimes we need to do different things. When people are having a refractory case of adrenal insufficiency, sometimes we have to switch the type of steroids and give one with a short acting that is more similar to the ones that we make in our body. That's hydrocortisone. That's almost never necessary, but sometimes it is helpful. That is split in 2 doses. So 2 points that I want to make about that. One is that once we're ready to start dropping down the prednisone, if for any reason someone is taking split doses of prednisone, sometimes twice a day, for whatever reason that is, before starting tapering the prednisone, it might be better to consolidate the 2 doses in 1 dose once a day in the morning. That imitates better what our body does. And then from there, start to gradually decrease the dose. When we have to switch to hydrocortisone, then we have to split the dose because we are trying to imitate the different times of the day when we have a surge of the steroid. So that's the hydrocortisone. In order to do the ACTH stimulation test, people have to switch from prednisone to hydrocortisone, ideally. And then 24 hours before the test, the hydrocortisone is stopped so that it doesn't affect the test results. So one more word about, and then I'll finish and open for questions, about adrenal insufficiency and how does that differ, or how is it different from steroid withdrawal syndrome? People tend to think these are the same things. They're not. They're completely different situations. Adrenal insufficiency, again, is when the adrenal glands do not make enough cortisol after someone stops taking steroids. And that leads to a situation of low cortisol. Steroid withdrawal syndrome is when someone is taking very high doses for a prolonged period of time, and their body, and that varies from one person to another, becomes tolerant and dependent of that high dose. And when the dose is dropped, they develop symptoms from that withdrawal, but they're still on a good dose of prednisone that will not lead them into adrenal insufficiency. So, like I said, the doses of adrenal insufficiency usually happens below 5 milligrams. So someone who is taking, for example, 30 milligrams of prednisone could develop steroid withdrawal symptoms if they drop, for example, from 60 to 30, and they had developed that situation of tolerance. It's almost a dependence on the high dose of steroids to have their bodily functioning well. So totally different situation. I hope I made this clear, but if not, please ask questions, and I'll stop here and open for questions.
Okay, thank you so much, Dr. Villaforte. We are getting questions right now, and I just want to say that as a reminder, we can't ask Dr. Villaforte to comment on any personal medical questions of our viewers. So make your questions general, and they will be appreciated by everyone and answered by Dr. Villaforte. And just before we start, I did want to also remind our viewers that we have some other great webinars on the Vasculitis Foundation's YouTube channel. There's one in particular from 2020 that will be linked in the follow-up email. That is a very, very deep, thorough, longer presentation about adrenal insufficiency and steroids in general. So if you're finding you need more information, that would be a wealth of information for you. So we are going to start with some questions. I promise to try to hit everybody's questions. I'll do the best that I can. We have some that were previously submitted by some viewers that couldn't be here today, and we have some that are being submitted right now. The first one that I want to ask is, someone says that when having adrenal insufficiency, are they more susceptible to infections and colds and things like that?
There shouldn't be, no. However, there's a lot more that is going on. A lot of people, when they stop the prednisone, they still are in another immunosuppressive medication. So the risk of infection is still there because of another medication. But once the prednisone dose is below 10 milligrams, the risk of infection, the immunosuppressive effect of the prednisone is very low. So a direct effect from low steroid, no.
Okay, thank you. And Dr. Villaforte, if you could stop sharing, I forgot to ask you that. That way we can see faces.
Let me see if I know how to do that.
Should be in your, there you go, perfect. So you're all set now. We see only faces. So one of the questions that I think speaks for a lot of people says, what are some signs of and symptoms of adrenal insufficiency or weaning too fast? You did say they were two different things, but people are confused about that.
What I said, the two different things is the situation of adrenal insufficiency and the steroid withdrawal syndrome. So adrenal insufficiency is oh, go ahead.
Oh, they were just asking, what are the signs and symptoms of one or the other so that you know which one you're having?
Great question. The symptoms are the same. I am sorry to say that, but the only way that you can tell one from another is from the dose of prednisone the person is taking. So steroid withdrawal happens when you're still taking a very good dose of prednisone. So at least 10 milligrams or higher, you're not going to have adrenal insufficiency. So if you're taking 5 milligrams of prednisone, then you could start to have some symptoms of adrenal insufficiency. But usually adrenal insufficiency happens more when you are on zero prednisone, zero steroids. So the difference between one and another is from the dose of prednisone you're taking.
Okay, thank you. And I did need to remind everyone that's watching today, if you want to submit a question, please put it in the Q&A box. Many of you are putting it in the chat box, and I will probably miss it there. So if you could just take a minute and put it in the Q&A box, that would be helpful. Is adrenal insufficiency inevitable if you reduce prednisone slowly over a 2-year period? At what dosage will it appear? I'm at 2.5 milligrams now. So this person's just asking so they can be wary of it, I guess.
Varies a lot from one person to another because the bodies are different. But as a general rule, the risk, so there are two parts of this question. The risk of developing adrenal insufficiency is very high. It's on anyone who's taken any kind of steroids for those rules that I gave before, the amounts that I showed before. It's up to 48% in studies. So a high risk of developing adrenal insufficiency. How can we try to avoid that? Doing a very slow and gradual taper. That how slow the taper needs to be depends on how long the person has been on the prednisone, how high the dose is. So it's a very individual choice the doctor has to make, taking everything into account. The fact that the person has been on prednisone in the past plays a role as well. So if someone has had multiple courses of prednisone, they're more likely to develop adrenal insufficiency. I would be more careful. If this is the first time that person is taking a course of steroids, then the risk is a little bit lower. So there are many factors that I'll take into account on how slow the prednisone dose. I might go a little bit faster, let's say until I get to 15 milligrams or 12 and a half, then slow down more as long as there's no steroid withdrawal symptoms. So remember, the doses, they're higher. If the person becomes tolerant to that high dose, at any level, they're going to have the withdrawal symptoms, not adrenal insufficiency. Now, as long as there are no withdrawal symptoms, I can taper a little bit faster at the higher doses. And then once we get to the close to physiologic doses, so let's say around 10 milligrams, I'll slow down and I'll go very slow. There's no rush.
Okay, and could you just review one more time as a follow-up to that? What are the symptoms that would be, since it would be either, what are those symptoms typically?
Okay, so the most common symptoms, like I said, very non-specific because there are aches and pains, joint pain, muscle pain, but people complain a lot of nausea as well. Rarely, but sometimes vomiting. Some people may have some headaches and low blood pressure. So those are, and a lot of fatigue. But as you know, you get fatigues and aches and pains with the disease itself. So it would have to be something new, something more intense that you wouldn't think is the disease as the person was doing better before. So it is not a diagnosis, but one that we can make in the clinic.
Okay, thank you. And so if this is from a patient, if one of the symptoms is fatigue, and fatigue is one of the most common lingering symptoms of ANCA vasculitis, even if we're in clinical remissions, how can my team determine if I have adrenal insufficiency without the ATCH test? And if someone does develop adrenal insufficiency, what do we do for it?
Okay. The adrenal insufficiency, the fatigue from adrenal insufficiency, as I talk to many, many patients and they describe to me, and I spend a little time trying to understand, is a little different. They will recognize there's something new, something different. It's almost described like a sensation of a low blood pressure, like maybe you're going to faint, maybe you're dizzy, a little bit different than what they were feeling with the disease itself. I know it's subtle, but it's something just to think about when we're trying to describe symptoms and the doctor's trying to understand. It's something that starts at one point in time at a low dose of prednisone. The fatigue from the disease has been there all the time. So something new, something more intense, something associated with other symptoms, maybe more intense nausea that was not present before. So usually people recognize there's something different about it. Now, one could get the ACTH, but even that test is not completely definitive because there is, again, peaks throughout the day. So I advise that if you're going to do the test, you have to get the baseline cortisol level anyway. Do it in the morning, like before 10 a.m. A better chance to get a better result. But even the ACTH stimulation test is not definitive. It could be wrong. So if I suspect someone has adrenal insufficiency, whether the test is showing that or not, I will treat. Now, the treatment is we have to go back on the dose of the prednisone or any type of steroid that is physiologic. So that would supply the needed cortisol levels to the body function. So usually doses of at least 7.5, 10. But it's an important question because sometimes I've seen people saying, oh, my doctor put me back on the 40 milligrams of prednisone. And I'm like, oh my gosh, you didn't need all of that. Just for adrenal insufficiency, you need as much as the body produces. And the body produces somewhere between 7.5 and 10 milligrams. And usually the majority of people, when I put them back on 10 milligrams, those symptoms will go away.
Okay.
Now for the steroid.
No, go ahead. Sorry.
So I think there was a part of the question about treatment for the steroid withdrawal, and that's important because the treatment is different. The doctor has to find out at what dose the withdrawal symptoms started. So for example, if someone was taking 60 milligrams, they were dropped to 40. The majority of people won't have any symptoms because of that. If anything, they'll be happy, less side effects from the prednisone, but they will not have withdrawal symptoms. Now, a group of people will have withdrawal symptoms, not adrenal insufficiency, because that's a very high dose of steroids. But they will, because the best way to say that is that, let's say their body got used to 60 milligrams. So when they are now exposed to 40, they're not functioning as well. So it's not adrenal insufficiency, is withdrawal of that dose that they were dependent on. Now, we can help take care of that. And normally what we do is, as a doctor, we have to figure out what was the most recent dose the person was taking before they developed the symptoms. We have to go back to that dose and not to higher doses. Otherwise, we're never going to get rid of the problem. So to give an example, if someone was taking 25 milligrams and then they dropped to 20, they develop symptoms. They drop to 15, they have more symptoms. They don't have to go back all the way to 30. At 25, they were not having symptoms. So that's the less dose that they took that they did not have symptoms. So we go back to that dose. This way we avoid the higher dose. And then we change the way we taper.
It sounds like as patients, we should really think about these things and write these things down as they happen so that when we go see our doctor, we can be specific with that information. It sounds like that would help a lot. The next question is, what happens to the adrenal glands in the case of a transplant? Do they shrivel along with the original kidneys?
No. The person will have their adrenal glands. There are different techniques for transplant. But one thing to remember is that when the person receives a transplant, they will be immediately placed on steroids for the reason of anti-rejection treatment. So for a while, people have to protect themselves from rejecting the transplant. That requires doses, initial doses of at least 10 milligrams. So they're not going to have this problem. However, I think the majority of the nephrologists, with some exceptions, will keep them on some prednisone for a few years. So that problem of adrenal insufficiency is not usually there, is not a concern. But they can taper off completely if their nephrologist allowed to. They'll still have adrenal glands there.
Okay, interesting. Are there forms of vasculitis that can cause I know you said you weren't going to talk about this, so you may choose not to, that can cause primary adrenal insufficiency?
It'll be very rare. I'm not going to say no because I actually have seen one case, but and I know it's possible. It is just an organ that is not usually a target for vasculitis, but it can be. Now, anything that causes inflammation and destroys the adrenal glands will result on adrenal insufficiency. That can be an autoimmune disease, a virus, a cancer, chemicals. No matter what destroy the adrenal glands, the end result is the same, is adrenal insufficiency. So if someone has a vasculitis that targets the adrenal glands, it will destroy the adrenal glands most likely. They're very sensitive and they can go into adrenal insufficiency. Now, if there's just inflammation, that might be reversible with treatment of the vasculitis, but don't think of it as a common target for vasculitis because it's not.
Okay. And one person asks, if you decrease prednisone to 0, do you always develop adrenal insufficiency?
No, the chances are, remember, about 48%.
That's what I remembered you saying, but I wanted to reiterate, thank you. A person is at risk for adrenal insufficient while they are reducing, this is phrased. Okay, so they want to know if I'm sorry, say that again.
I'm sorry. I just want to go back to the last question about the percentage. When I say the percentage of people is not the percentage of people developing adrenal insufficiency, the risk is 48%. I don't see that many, but I'm always super cautious about tapering the steroids. So I actually see a small case. But when we think about 48%, we're not taking into account how are these people being tapered? They're steroids being tapered, right? We're putting everybody together. So the risk is very low if the taper is done very well, very carefully.
So thank you. And this next question says, a person is at risk for adrenal insufficiency while they are reducing, and then 12 months after stopping completely. They want to know, I think, could they have adrenal insufficiency 12 months after they've been completely off?
They could, up to 12 months after they could. It's that as time goes by, it becomes less and less frequent, but you can still have adrenal insufficiency up to 12 months after stopping the prednisone.
Okay, and the next question is there a method that works to reduce steroid dependence? Because a small, I just lost my question.
I think I know.
You will go ahead.
No, the beginning of the sentence was easy to make it up. Yes, there are ways of trying to decrease the chance of having the withdrawal symptoms and the dependence intolerance. We try not to stay on the same dose when it's a very high dose for too long. So this is a very modern way of approach. When I trained, and this was 100 years ago, we had to give a very high dose of steroids to save lives and keep that high dose going for 4 weeks before we start tapering. We don't have to do that very often anymore. We approach the treatment with a very different perspective in our days based on so much research, but also because we learned how to use the steroids much better. So the majority of people don't need to stay on such a high dose for such a prolonged period of time. Sometimes maybe just a week. So that decreases the chance a lot. The longer the person is on the same dose, very high dose, the more likely that tolerance. And also, if possible, when the duration is longer, not to drop to not in a huge gap. So for example, if someone has been on 60 milligrams, let's say for 4 weeks, for whatever reason that was, and they drop to 30 or 20, that is a huge drop for that person that was seeing 60 milligrams for so long, as opposed to someone who was just on a week of 60 milligrams. So increases the risk of withdrawal. So we have to be careful with the duration and the drop on the dose by how much.
And it sounds like the best thing for the patients to do is trust their doctors, but communicate if they're having problems. Is that what you would agree?
Absolutely, because we don't know who is more prone to develop it or not. So any new symptoms, anything that is not expected as the treatment goes, ask. It's never wrong to ask. It's never asking too much. If you're in doubt, that means something could be going on that we can address.
Great, thank you. And what can patients do as they taper off prednisone in order to get the adrenal glands to kick in and start making sufficient amounts of cortisol again? This is similar to another comment, which was, are there any natural therapies that can help wake up the adrenal? So is there anything we can do, basically, is what they're both asking.
I wish there was something proven that we could do like supplements or there's really nothing or a treatment that is available that would wake up the adrenal glands. One of the things is the adrenal glands get smaller. So one of the things that we need is time, because they need to grow a little bit more in order to start producing the cortisol. And that timing of growing varies from one person to another. As this is happening, sometimes I will keep someone, I think someone mentioned their question, in a very low dose. And I try to find what's the lowest dose possible that they don't develop symptoms of adrenal insufficiency. Sometimes somewhere between 2.5 milligrams and 3 milligrams is enough for a lot of people, and give them a little longer as their adrenal glands are growing with a little bit of prednisone so they don't have symptoms. Because in a dose such as 2.5 milligrams, the adrenal glands are being stimulated, so they will have to start working at some point. So it doesn't have to be completely off steroids for them to start kicking in. They have to start kicking in once you are on 5 milligrams a day. So I would advise that once you get to 5 milligrams, plan with your doctor how slow you can do it, especially because the side effects from low dose of prednisone are not there anymore. And once you get to 5 milligrams, most of the side effects are going away. So slow down the taper between 5 and 0. That's your best chance of not developing adrenal insufficiency.
Okay, thank you so much. Maybe that'll help all of us be a little bit more patient with why it's taking so long to completely get off of steroids. That is something the doctors are taking into consideration. This next question is, so if repeated cortisol tests show return of cortisol levels to normal levels, then there is no longer adrenal insufficiency. Is that correct? And how long does prednisone withdrawal last? Oh, that's another good question.
Okay, that's a great question, because if you do the cortisol level at least a couple of times in different times of the day, maybe, and you have the basal number, the lowest number at the normal range for that time of the day, I think you can trust that. Or one time only cortisol level might not be definitive, because at other times of the day, you might be going too low and not being aware of it. So test a few times if you want to go by the test. In order to know if you are not in adrenal insufficiency, then the ACTH test is a little bit more helpful. It's not always definitive for adrenal insufficiency, but the other way around, it is. It's usually not necessary, because by then, people don't have symptoms of adrenal insufficiency. If there are no symptoms of adrenal insufficiency, if the doctor's not worried about that, and we take other things into account as well, your blood pressure, your heart rate, sometimes we look at some blood tests like sodium, potassium, and other electrolytes. If everything looks good and you're not having symptoms beyond the fatigue that you recognize from your vasculitis, I don't think the doctor will order the test. They'll just monitor and trust that your adrenal glands are kicking in.
Okay, great, thanks. I've had a couple of people ask about, does adrenal insufficiency, do you usually recover from it, or is there a chance that it can be a permanent situation?
Great question. It's rarely a permanent situation. There will be the case here and there, but patience is everything. I'll tell you what, sometimes the majority, great majority of people will recover. It sounds like someone has not recovered after 1 year. It's okay. Don't give up. I remember someone that had been on prednisone for many years because of asthma, not because of the vasculitis, but was able to taper so slow. It took me years, but that person eventually got off the steroids. So sometimes we're losing hope because that didn't happen within a year. Keep going very, very slowly. Sometimes we alternate the doses. I hate to say that because I don't want anybody to rely on that for treatment of vasculitis, but in a situation where we're just trying to avoid adrenal insufficiency on someone who's been very difficult to come off the steroids, we have other techniques that we can try. Other strategies like alternating doses or going a whole month on the same dose and then a whole month alternating dose. There are so many creative ways, so you should not give up. If you really want to come off the steroids and it's been hard, keep trying. It may take a few years or longer, but it is possible. The majority, great majority of people can come off the steroids without adrenal insufficiency. If it's very hard, remember, try and talk to your doctor if it would be a wise idea to switch to hydrocortisone. Remember, I mentioned that. That's the short-acting steroids that it mimics better our own steroid.
Okay, great. Thank you. A couple of people are asking about adrenal insufficiency or while they're taking other medications. One says if you're having methotrexate as you taper and stay on it, will that avoid adrenal insufficiency? And the other person says, does it happen while you're taking avacopan?
When you are on other immunosuppressive medications such as methotrexate, azathioprine, rituximab, they do not have a steroid component, so they will not prevent adrenal insufficiency. The adrenal insufficiency will happen or not independent of the treatment that you were taking. The question about avacopan is the idea of substituting avacopan and using that instead of prednisone is for treatment, not because avacopan is a steroid. So avacopan is not a steroid. So if someone is taking a steroid and is hoping to take avacopan to avoid adrenal insufficiency, that's not the way to go, because you're still going to lack the steroids if you've been on that for a very long time. So the story about avacopan is different on how you would decrease the exposure to prednisone, which is true. That's the whole purpose of using avacopan to treat the vasculitis, but not to avoid adrenal insufficiency.
Okay, thank you so much for clearing that up. And I think you addressed this too, but maybe review. Someone says, can you explain what a rescue dose is? And they also said, thank you for the wonderful talk.
Thank you. A rescue dose, and I'm sorry that was not clear in the slide, is how we refer to for asthma. So we sometimes call it rescue inhalers. So when someone starts to have more symptoms of asthma or an asthma attack and they use their inhaler that they don't use every day, that's a rescue. It's rescuing them from having a severe asthma attack. And that contains a lot of steroids.
Okay, thank you. I don't know this word, but it looks like budesonide is reported as having fewer systemic effects than prednisone. Does it have the same risk of adrenal insufficiency?
It does, because it is steroids. So remember that any kind of steroid can cause adrenal insufficiency if it is, but at different doses. So if it is an equivalent dose. So 5 milligrams of prednisone is the same as 4 milligrams of Medrol. So obviously the dose that would cause adrenal insufficiency is different. Hydrocortisone is 20 milligrams, the same as 5 milligrams of prednisone. So obviously we have to do the equivalent dose. But any form of steroid, and budesonide is a form of steroid, when used for prolonged periods of time at such a higher dose, will put at risk of someone to have adrenal insufficiency.
Okay, thank you. And this next question is about, it's very politically correct. Does advanced age affect the ability to recover from adrenal insufficiency? I appreciate that because my advanced age would like to know.
I don't know that, and I did review this literature because I'm actually giving a talk about that in September, but I did not come across a specific research that looked at that very well. There are some hints here and there in the research world that it's possible that older, and when they call older people, they put that limit at 65 years old. So that's not fair, right? But They look at that as one possibility for a little bit slower recovery, but not necessarily that would impact their ability to recover. But
Okay.
that's very subtle. I don't put a lot of faith in that.
Okay. Well, thank you. Well, we want to hear what you think, so we appreciate that. This next question, does DHEA help with steroid reduction?
No, I'm thinking someone is asking about prednisone reduction. So when they are saying steroid, they're probably referring to prednisone. The answer is no. It would be very complicated to explain why, but there's a completely different form of steroid. So it should not be used for that intention.
Okay. And back to the question of can we do anything to help ourselves? Does exercise enhance cortisol production?
In a way, it does, because you need a steroid level to body functions. So think about all the body functions that we are not really consciously think about it every day. Our heart rate, our ability to breathe in and out, all the bodily functions that are automatically happening in our body that we don't think about it, our blood pressure, we just go about our lives without thinking, those are usually steroid dependent. So if you think as a general rule that all those bodily functions depend on steroids, then you depend on a good oxygen level to exercise. So exercise will tell your body that you need more oxygenation, more input of blood flow to your muscles. So I think that is a great idea. I don't think you're going to start all of a sudden to do intense exercise, but start slow. Frequency is important, so doing it at least 4 times a week, so more frequent, short periods of time and less intense exercise is better to increase endurance, energy, and that will help.
Okay. Thank you. It's worth a try. Can adrenal glands work part-time? That is to supplement a daily low dose of prednisone of 5 milligrams of prednisone or less.
They can. I don't think we can measure that part-time. I cannot tell what's the percentage on how it's working. We don't have the ability to do that. But yes, there are some people that clearly they need just a little bit. So I know that they're producing some. So to give an example, someone might not feel they're able to come off the prednisone and they develop symptoms every time they try to go to 0. But when they're taking 2.5, they feel completely well, and that's enough for them. Well, I do know that 2.5 is not enough for our body to function well. So I do know that they're making some. So that's an indirect way to conclude that they're making some, but maybe not enough.
Okay. Well, thank you. Someone wants to know if treatment is to go back on prednisone, how do we get off it? I think you answered that one, so I'm going to move past that one. But if you go through steroid withdrawal, is it dangerous to push through and continue to taper?
It's not dangerous in terms of something bad is going to happen, but people are usually having very intense symptoms. It's hard to tolerate it. So I would advise not to try too hard. It's not worth it. We don't have to push the dose higher than before. We'll just have to adjust the taper. The other way to look at it is not to stay too long on the same dose. So maybe try in a situation like that to drop down the dose every week instead of every other week, or instead of every 3 weeks, but at a shorter increments or decrements.
Okay, thank you. And this person is asking, is low glucose a symptom as well? I'm not sure if they meant of prednisone withdrawal or if they meant adrenal insufficiency, but that's the question.
No, that's a different part of the adrenal glands that produces a different kind of hormones. That's why the blood pressure is not only dependent on the steroids that we're talking about, but the glucose should not be affected, not significantly.
Okay, and somebody's saying, how do you measure that the glands are growing? Do you use a scan?
No, it's not even a scan or an ultrasound or a CAT scan can detect that. It's almost at the microscopic level. So no, there's no way for us to measure that difference that would tell it. And we don't do this kind of test, because even if they grow, there is a possibility they're not making enough steroids. So the size itself is not important to be measured.
Okay, and this is probably a common thought from some patients. It seems that a lot of doctors think it's better to get off prednisone as soon as possible and are following an outdated tapering schedule. Is there a standard slow tapering program that can be given to doctors? Where do we find this information if there is?
This is not wrong what they're saying. We, and including me, would love to get rid of the prednisone as soon as possible. And the modern way to approach to the treatment of vasculitis is to ask the following question on day one of prednisone: when can I get rid of it? So yes, our plan should be to use the least amount of prednisone for the shortest duration possible. But however, that changes from one person to another, one vasculitis to another, and we do the best we can. We use other medications sometimes to allow for a quicker taper of the prednisone. When we're talking about adrenal insufficiency, we're talking a situation that the person has been on the prednisone for a while now. So this is kind of two questions in one, right? So it is correct. I want to get rid of the prednisone as soon as I can, but I have to do that cautiously. There is no specific protocol or guidelines. If you look at the studies, then you will see the way that they decrease the prednisone. I will just make a comment about the studies. If you look at European studies, if you look at US studies, they taper a little bit different. This is available online if you look at the whole study, and the doctors are looking at that. So we call the Paxivaz steroid taper. That's the Paxivaz study, and we use that a lot in clinic. But a lot of these studies are not long enough, and they're not reporting patients that develop adrenal insufficiency later on. So we don't really know the full impact of those tapers they're using in the studies on adrenal insufficiency risk. So one thing is going by those protocols that already exist, and the other thing is trying to, which I think is wiser, to adjust the protocol for that person in front of us that might have other factors that impact their taper. But yes, I'm always looking into the possibility of a taper that can get rid of the prednisone as soon as possible.
Okay, thank you so much. And I know there are more questions, but we are so close to the hour and we are out of time. And I appreciate so much. I learned so much. I got many, many, many compliments in the chat boxes about how much they appreciated your time today. So we do appreciate that. And I did want to remind our viewers that there are some other great webinars on the Foundation's YouTube channel about this topic. So go there and look for more information. We gather the questions that are in here that are not answered, and we do attempt to do a recorded version of this, not live, down the road to make sure we get all the questions answered. Perhaps we can ask you to come back and do that somewhere down the road, Dr. Villaforte. Thank you so much for that. That would be great. And I just wanted to say again, thank you for taking your time with us today. As a reminder, this has been recorded and will be published on the YouTube channel. Each person will get a link in an email as soon as it's ready. And before we finish up, I just want to talk to my fellow patients here. Did you ever wonder what you could do to have an impact on important vasculitis research? The answer is that you could join the VPPRN. The VPPRN, the Vasculitis Patient Powered Network, is something that I am a patient champion for, and I encourage other patients to join the VPPRN and to complete their biannual forms. You'll start hearing about those soon. Twice a year, we ask you to take like 10 minutes and just do an online form and complete it for us. So I encourage you to learn more just by visiting their website at vpprn.org. What I can tell you is it's a global patient registry. Patient data, that means your patient data, drives all the research in vasculitis. And so providing researchers with information about you and your experience is your way to help advance the knowledge of vasculitis. And we would like to thank the Vasculitis Foundation for hosting these webinars, including our sponsors, Amgen, AstraZeneca, and Novartis, and of course, Dr. Alexandria Villaforte for spending all this time with us today. I think it was great, all the information that we got today. I really feel like I learned so much. And thanks to the Vasculitis Foundation for supporting educational webinars for our patients and doctors. And thank you, Dr. Villaforte.
Thank you for having me. All right.
And that's it. Goodbye, everyone.
Goodbye.